Fracture consults are the bread and butter of orthopedic surgery. I realized while putting this course together that it's hard to talk about individual fractures without talking about fractures as a whole first. So here are the fundamentals of fracture workup. Many talks try to talk about every detail you could possibly imagine. I'd like to go the opposite way. What is the least amount of information you need to gather to do a thorough evaluation? In the HPR, there are 4 questions you must ask. In the past medical history, there are only about 7 diseases that orthopedic surgeons really care about. The presentation needs to be concise yet still have all the information the surgeon needs. If you can do this, you'll be seen as a well-trained, experienced PA, even if you're new to the job. Here are the 4 questions you must ask all patients with a fracture. What happened, when, their baseline activities, and their NPO status. What happened? In other words, what is the mechanism of injury? The main decision here is this a high energy injury or a low energy injury? The lowest energy injury would be a mechanical fall from standing height, kind of like our friend in this example. By mechanical fall, we mean someone tripped over an object. The highest energy injuries we see are generally from motor vehicle accidents. When someone is in a car crash, you have to parse out, was this a high-speed crash or a low-speed crash? Did the airbags deploy? Was the patient seatbelted? Was the car totaled? Or was it just a fender bender? Similarly, if the patient fell off of a ladder, how high? If they fell down steps, how many steps? Remember, when talking to the attending, you will have to communicate whether this was a high energy or a low energy injury. When did this happen? Fracture care is completely different if the fracture is acute, subacute, or even chronic. Chronic meaning generally 3 months or more. Whether hours, days, weeks, or even months, you have to know this information. What is the patient's baseline activity? The same fracture is treated completely differently if the patient is bedridden, walks with a walker, or does high-level activities like CrossFit. If you work in an ER, you have to get used to asking, when's the last time you ate? Also find out exactly what they ate. Was it a full meal or was it just a drink? If this is an urgent situation that needs anesthesia, the timing largely depends on their NPO status. Put it this way, if you're talking to your attending and he asks, is the patient NPO? And if you can immediately respond with, the patient ate this at this time, you'll be seen as a rock star. I happen to love reading Sherlock Holmes mysteries. I've read them all. And in one mystery, Dr. Watson asks, how did you find that clue? To which Sherlock Holmes replied, because I was looking for it. When it comes to past medical history, you have to be like Sherlock Holmes. You have to search for certain clues. Once you understand why the orthopedic surgeon cares about these clues, they start to stick out like a sore thumb. Here's a mnemonic I made for this talk. A, B, C, and the 4 Ds. A is for anticoagulation. If they are on blood thinners, which blood thinner and why? Is it atrial fibrillation, a DVT, a PE, coronary artery disease? And when was the last time the patient took it? B stands for body habitus. If the patient weighs 400 pounds or the extremity that is broken is morbidly obese, believe me, the surgeon will be eternally grateful if you warn them ahead of time. C is for cardiac disease. Cardiac disease, number 1, determines whether the patient is a surgical candidate. And 2, it may delay the surgery time if the patient has to see cardiology prior to surgery. The 4 Ds, dementia, diabetes, drugs, and dialysis. Dementia is very important because we have to know if the patient can be trusted with certain post-treatment protocols. Can they tolerate restricted weight bearing? Can they understand posterior hip precautions? Can you even trust them to keep the brace or sling on their arm? Or is it better to maybe use a cast? If a patient has diabetes, you need to know if they are insulin dependent. Extra gold stars if you find a recent A1C. We work in an urban environment here at St. Agnes, so drugs are an unfortunate reality of what we do. Being an active drug user is a great reason not to operate on someone. Their surgeon needs to know that. The same goes for cigarettes. When it comes to dialysis or any other kidney disease, that immediately impacts the bone quality. This will change not only if we will decide whether the patient needs surgery, it will change the construct that we would use during the surgery. The physical exam. When you go to evaluate the patient, my best advice is to ignore the injury. You want to examine the broken limb last. Do a complete evaluation from head to toe. You want to feel the head, feel the upper extremities, feel the lower extremities, even feel the abdomen. Once you've done that, this will protect you from missing polytrauma. Question 1, is this an open fracture? You have to look at the skin. And often that means taking down clothes, taking down field dressings like in this picture. As a senior resident once told me, if you get a gift, you gotta open the gift. Number 2, is the patient neurovascularly intact? The neuro exam at its minimum should be sensation. If the wrist is fractured, ask if they can feel the entire hand. If the ankle is fractured, see if they can feel the entire foot. For the vascular exam, always check the pulses distal to the injury. That's going to be the radial pulse for the upper extremity, the dorsalis pedis for lower extremity injuries. Don't forget that the palmar arches are very important blood supply for anything distal to the wrist. You should learn how to get a Doppler and Doppler those palmar arches. Question 3, is this compartment syndrome? Any fracture should have a soft tissue or swelling evaluation. The surgeon will often delay surgery if the extremity is too swollen to safely undergo that incision. A simple test would be wrinkling the skin. Take your 2 hands and try to wrinkle the skin. If it wrinkles, it's usually safe for surgery. If it doesn't, it's too swollen. Again, your surgeon will love you if you can warn him or her that the limb is too swollen for acute surgery. Checking x-rays. I can think of no more important rule than one view is no view. There are so many examples, I'm going to include one here. Here is a mortise view of an ankle. Overall, it looks quite normal. You could argue there is an avulsion off the lateral mal. You might say that the medial clear space is slightly open, but all in all, this is a normal appearing x-ray. If you should choose to send this patient home with an ACE wrap and say follow up in 6 weeks, we've got a big problem because the lateral shows a rather large posterior malleolar fracture. This makes this an unstable operative fracture. If this is ignored, it could have devastating consequences for the patient. When it comes to how many x-rays you should order, this is my general rule. If a bone is broken, get the entire bone. If the ankle is broken, get the entire tibia-fibula view. If the hip is broken, get the entire femur. Here is one case. A patient falls and has this hip fracture. Typically, this is treated with a long cephalomedullary nail. Before you do that though, since you are a great experienced PA, you get an x-ray of the entire bone. And now we have a totally different situation. Because of that stem knee replacement, we could not fit a long nail down that femur. If you alert your surgeon to this, that's a great pickup. Some people advocate for a joint above and a joint below. That might be overkill. Remember, these people are broken and you don't want to needlessly torture them. On the other hand, no one's going to fault you for ordering more x-rays, so when in doubt, order the extra x-rays. So, you've gathered all the information. You've taken a good history. You know what happened, when, their basic activity levels, and the last time they ate. You've done a good physical exam, including a complete survey of the entire body. You've Sherlock Holmes a past medical history, and you've made sure we've had adequate x-rays. Now comes a presentation. I hate to admit it, but I had a pretty bad reputation as an intern. It wasn't because I was lazy or because I was an idiot. It was because my presentations were all over the map. To spare you that fate, here is a recipe for a basic fracture presentation. Let's go through it. Start with a blank-year-old male or female. Then you describe the mechanism of injury. Remember, we're trying to highlight, was this a high energy injury or a low energy injury, or somewhere in between. Make note of the time of injury. Next, describe the fracture. This includes describing the x-ray, but don't go crazy about it. Generally, all we need to know is it displaced or not displaced? Is it open or closed? You can say neurovascularly intact if it's true. Always make a note of the swelling. Add the history of anything that would be pertinent, the ABC and the 4Ds. And finally, go through your plan. In an open fracture case, this should always start with what antibiotic you plan on using, and then what sort of immobilization you plan on using. Presentation 1. I have a 25-year-old male who was in a low-speed motor vehicle accident 10 days ago. He has a non-displaced right tibial shaft fracture. He was neurovascularly intact with mild swelling. Already the attending is feeling pretty relaxed. This is a subacute low-energy injury without displacement, and there's no compartment syndrome. You go on. He is diabetic on insulin with a history of cocaine abuse, and he smokes a pack per day. We were already probably headed towards a non-operative route, and the past medical history pretty much seals the deal. You present your plan to splint the patient, then await further decisions by the attending. Presentation 2. I have a 25-year-old male who was in a high-speed motor vehicle accident 6 hours ago. He has an open right tibial shaft fracture with 20 degrees of angulation. After 2 sentences, we are already in a whole different world. There are some immediate concerns in the mind of the attending, but before he can ask, you continue. He is neurovascularly intact with moderate swelling. His compartments are soft. He is otherwise healthy. So this is clearly an operative fracture. The attending has a good idea that this is not an emergency right now. You describe your plan, ANSEF tetanus, and a long leg splint. So you've shown you can present this case. You're already thinking along the same lines, the same pitfalls that the surgeon would be thinking about. Could this be a compartment syndrome? Do I have to do this right now, or can I wait a day possibly? In other words, you're awesome. Presentation 3. I have a 25-year-old male who was in a high-speed motor vehicle accident 6 hours ago. He has an open right tibial shaft fracture with 20 degrees of angulation. He has decreased pulses. His sensation is decreased in his dorsal foot, and his compartments are firm. He is healthy otherwise. So now, of course, we are in an emergent situation. This is bad. But it goes a long way to your attending if you can identify a bad situation and let him know about it appropriately. Plan is ANSEF, tetanus, a long leg splint, and I do have concern for compartment syndrome. So whether it's a simple non-operative fracture or a fracture with an emergent component like compartment syndrome, it's important you relay that information in a succinct and clear way. That's going to go a long way for the attending trusting you and seeing you as a well-trained, experienced, gold star type PA.